Welcome to The Explainer. Today we're going to build a practical framework for managing the symptoms of multiple sclerosis. Now, we're not talking about the big disease-modifying therapies today, but something that, for many patients, is just as critical. Our goal is to give you, as medical trainees, a repeatable model you can use to tackle the daily challenges your patients with MS are facing.
So let's kick things off by getting right into the patient's world. This quote, it's from a huge patient survey, and it says so much. We as clinicians, we tend to focus on relapses and what the MRI looks like. But for 2/3 of patients, the single worst part of their disease is just being tired. Think about that for a second. It really forces you to ask, are we focusing on what matters to us or what really matters to them? It makes it crystal clear that managing symptoms isn't some side quest, it's the main event.
Okay, so before we dive into any one specific symptom, let's just establish a mental model. This is going to be the foundation for everything else, whether your patient is dealing with fatigue, spasticity, or bladder problems.
And here it is, your 3-step guide. First, and this is the most important part, you have to play detective. Before you blame MS for a new or worsening symptom, you have to rule out other causes. Second, go for the non-pharmacologic strategies first. You'd be surprised how often the evidence is stronger for them. And then, and only then, do you get to step 3, where the real art of medicine comes in. You individualize. You pick a treatment for the unique person in front of you, not just for the symptom they have.
So let's put this framework to the test. Section 2. We're doing a deep dive on the most common symptom in MS, fatigue. And let's be clear, this isn't your "I didn't get enough sleep" kind of tired. This is a profound, deep exhaustion that can just crush a person's day.
So picture this. Your patient comes in, they're complaining of this debilitating fatigue. Your first instinct might be to think, what can I prescribe? But nope. Following our framework, the very first question you have to ask is, what else could this be? This is step 1, rule out mimics, in action.
And wow, that list of potential mimics is pretty long. You got to ask yourself, are they even sleeping through the night? Or are spasms or bladder issues waking them up? Could this be depression? Have you checked the basics, like a CBC for anemia or a TSH for thyroid problems? What about sleep apnea? Are there other meds causing this? You get the idea. Every single one of these is treatable, so doing this thorough workup isn't optional. It's non-negotiable.
Okay, so you've done your due diligence. You've ruled out the mimics. Now for step 2, non-pharm first. And honestly, this is where the evidence gets really interesting and maybe a little surprising. It turns out things like exercise and cognitive behavioral therapy actually have pretty good data showing they help. But what about the drugs we so often reach for? Well, a major trial put some of the most common ones, amidine, modafinil, and methylphenidate, head-to-head against a sugar pill. And guess what? They were no better than placebo. That's a huge takeaway.
All right, let's shift gears. Section 3, tackling motor symptoms. We're talking about the stuff you can often see, like spasticity and trouble walking, which, as you can imagine, can totally upend a patient's independence.
So what is spasticity, really? Well, it's way more than just feeling stiff. The key phrase to remember is velocity dependent. That means the faster you try to move a limb, the more it resists you. It can show up as either this constant tonic stiffness or as these jerky phasic spasms that can be a total nightmare for patients, especially at night.
You can't manage what you don't measure, right? The Modified Ashford Scale is a super simple tool we can use right at the bedside. It goes from 0, which is normal, all the way up to 4, which is a rigid limb. But here is the crucial clinical pearl. You are not always aiming for a 0. Sometimes a little bit of that tone actually helps with stability. The goal is to find the sweet spot, just enough relief to improve function or comfort without making them so weak they can't move. Once you and your patient agree on that goal, then you can think about first-line meds like baclofen or tizanide.
Okay, this number, 35%, this represents a huge lesson in how we should think about treatment. It comes from a trial for delphompredine, a medication that can help with walking. See, if you looked at the average improvement for everyone in the trial, it was just, okay, nothing amazing. But for this 35%, this group of responders, the improvement was real and it was meaningful. The lesson for us? In a disease like MS, where everyone is so different, you have to stop looking at group averages. Your job is to find the individual responders, the people who truly benefit.
Now for section 4, addressing pelvic dysfunction. This is a big one. It's incredibly common, but it's also something patients can be really hesitant to bring up. We're mostly talking about bladder issues here, and they can be just socially isolating. And the absolute key to managing them is figuring out exactly what's going wrong.
You can basically boil it down into two main buckets. Either the bladder can't store urine properly, or it can't empty properly. Now, as you can see, most people, about 60%, fall into that first bucket. Their bladder is overactive, it fails to store, and that's what leads to all that urgency and frequency. But look, a big chunk of patients has the exact opposite problem. They fail to empty. And if you treat a failure to empty patient like they have a failure to store problem, well, you're going to make things a whole lot worse.
And that brings us to a really, really critical clinical pearl. This is a safety issue, plain and simple. Before you even think about prescribing a drug like oxybutynin for urinary urgency, you have to check a post-void residual, a PVR. Why? Because those drugs make it harder for the bladder to empty. So if your patient is already retaining a lot of urine, you could literally push them into acute urinary retention and set them up for infections. So check the PVR, always.
Let's move on. Section 5. Now we're going to talk about what's often called the invisible burden of MS. These are the symptoms you just can't see on a physical exam, but they can be absolutely devastating. I'm talking about things like cognitive impairment and depression.
This slide is so important for how you counsel your patients. Because you see that first number, around 70%? That's the percentage of patients with some level of cognitive impairment. And that sounds terrifying, right? But then you look at that second number, frank dementia, it's really, really rare. Less than 5% of patients, and usually only in very advanced disease. Being able to explain that distinction is absolutely key to reassuring your patients and their families.
So what does that cognitive impairment actually mean for the patient? Well, it's usually things like their mental processing speed slows way down. They might have trouble with short-term memory or with planning and organizing things. And here's the tough part. We don't really have any pills that are proven to fix this. So management is all about teaching, coping, and compensation strategies, often with a huge assist from our colleagues in occupational and speech therapy.
Now, when it comes to depression, which is also super common, we can be a lot more strategic. This is a perfect example of our third principle, individualizing therapy. Don't just pick a random antidepressant. Look at the patient's whole symptom profile. Do they have depression plus neuropathic pain and fatigue? Well, hey, an SNRI, like duloxetine, could hit all three of those things. What if it's depression and fatigue, but no pain? Maybe bupropion or fluoxetine is a better choice. See what I mean? It's about treating the whole patient, not just a list of problems.
So, as we bring all this together in Section 6, here's the key takeaway. Managing MS symptoms isn't about playing whack-a-mole with a series of disconnected problems. It's about weaving all these principles together into a plan that treats the whole person, not just their disease.
Because at the end of the day, what's the goal here? It's not just about getting a better number on a spasticity scale or shaving a few seconds off of walk time. The real goal, the one that truly matters, is to partner with our patients to help them restore their function, to help them keep their roles at work and at home, to improve their quality of life.
And that brings us to our final and maybe most important point. You cannot do this alone. It's just not possible. Effective symptom management in MS is a total team sport. So I'll leave you with this one question to ask yourself for every single patient you see. Who else needs to be on this person's team? Do they need a physical therapist for their walking, an occupational therapist for energy conservation, a urologist, a psychologist? Building that multidisciplinary team, that might just be the most impactful thing you can do for your patient with MS.